As we've said before, stem cell therapies show so much promise, but sometimes they seem to elucidate a little bit more frustration than they do illumination. But this time around, it should be very interesting. We're with Dr. Roberto Bolli, Chief of the Division of Cardiovascular Medicine and the Director of the Institute of Molecular Cardiology at the University of Louisville. And we're talking about SCIPIO. Great name for a trial, by the way. Now, at this meeting of the American Heart Association, Poseidon had positive results, you had positive results, then there was Swiss AMI, and not quite so. Tell me some background first. Why did you do this study?
So we did this study because we wanted to test the potential usefulness of cardiac stem cells. This is the first clinical application of cardiac stem cells, and we had a tremendous amount of evidence in preclinical models of ischemic cardiomyopathy that these cells are very efficacious in improving ventricular function, limiting remodeling, and regenerating dead myocardium. We did a lot of studies in mice, in rats, in pigs, and all of them, they really revealed a very remarkable effect on the endpoints I just mentioned. It also stands to reason that since the function of these cells in the heart is to regenerate the myocytes that we continually lose during our lifetime, that maybe these are the best cells to use to repair the heart because their job description is to make new myocytes to start with. So we applied to the FDA in 2006. We received approval to do the study in 2008, started recruiting in 2009, completed the recruitment in 2011. Now we are following up a few more patients.
And so what did you find in this particular study?
We found that in patients with ischemic cardiomyopathy, meaning ejection fraction less than 40% and at least one previous transmural infarction, the infusion of autologous cardiac stem cells produces a remarkable increase in ejection fraction. At 2 years now, we see a 12-point increase in ejection fraction. Produces a reduction in the size of the scar, an increase in viable tissue measured by MRI, also a decrease in the New York Heart Association functional class of almost 1 unit. So patients start out in class 2 on average, and now most of them are in class 1. And also an improvement in the quality of life measured by the Minnesota Living with Heart Failure questionnaire. About 22 points improvement at 2 years.
That's really good.
And we also found, perhaps most importantly, which is the reason we did the study, was we did not see any adverse effects of these cells.
Which is very important. In terms of what I was saying at the beginning, sometimes it seems like these trials, they frustrate as much as they illuminate. What have we learned in the last few years that allows you to have the knowledge to come through and do a positive study like this? Is it going to get easier as we go on? I mean, are we going to find more frustrating studies? What is it that explains the stem cell experience?
Well, I think the whole enthusiasm about stem cells stems from the realization that every therapy we have now for heart failure is fundamentally a palliative therapy. Correct. We are maybe prolonging life, but certainly not addressing the underlying fundamental problem, which is the loss of viable tissue. Stem cells are exciting because they have the potential to tackle that fundamental problem, to replace a scar with viable tissue. And so there has been a lot of enthusiasm. I personally believe this is not hype. I don't think this is going to be a fad. I think this will fundamentally transform the way we practice medicine in the near future. It must be noted that worldwide there have been more than 2,500 patients, cardiac patients who have received some kind of stem cell, and there has been no adverse event that can be ascribed to cells so far. So at least these cells appear to be safe, which is obviously the most important thing. And then if you do a meta-analysis of all the stem cell trials performed so far, you do see a significant beneficial effect on ejection fraction, on even mortality in the most recent meta-analysis, as well as on the size of the scar. So I think there is enough safety already shown and enough evidence of beneficial effects to pursue further studies of these cells. What we really need are phase 3 trials with hard endpoints. There are 2 such trials, as you know, that are about to be launched. One in Europe, the BAMI study, which will use bone marrow cells, and one in the United States, the RENEW study, which will also use bone marrow cells.
I think we're also learning that specific cells matter. You know, what cells you choose, how you decide to place them matters. The patients matter. So
Absolutely.
I think hopefully we are getting better and we'll see more positive trials and fewer of the frustrating ones.
Absolutely. So to me what's really remarkable is that here you have a totally new therapy, cell therapy, which has only started in the last 10 years. We have no idea, as you said, what is the best dose of cell, what is the best way to give them, what is the best time to give them, what is the best cell type, and what is the best patient population. And despite this, the very first time we tried them, many studies report positive effects. To me, that's really amazing. And I think, once we learn how to deliver them, how to choose them, how to dose them, how to select patients, I think the effects can be clearly improved, and we are just at the beginning of a learning curve, and there is a lot of room for improvement in terms of utilizing these cells wisely.
Thank you, Dr. Bolli. I appreciate your time.
You're welcome.
For CardioSource World News, I'm Rick McGuire.